Are you gearing up for radiology board exams? The Radiology Review wants to save you money. Visit our discount code section for current offers on Radiology Review recommended educational resources. Head to theradiologyreview.com and navigate to the discount code section. Terms and conditions apply. Limited time offer. Discounts may vary. Welcome to the Radiology Review podcast with your host, Dr. Matt Covington, a board-certified radiologist. For additional content, please follow the Radiology Review on social media, such as X or Instagram, at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website, theradiologyreview.com.
Welcome back to the Radiology Review podcast. In the next two episodes, I will cover key concepts for esophageal imaging on fluoroscopy. Thereafter, I will continue the theme of fluoroscopy and cover disease states evident on a barium evaluation of the bowel, and close with a more general question and answer type discussion of radiation dose and fluoroscopy. I am addressing this topic based on listener requests, and I agree that these episodes should be very high yield for radiology board exams. Not only do we discuss fluoroscopy, but there are simply many important diseases of the gastrointestinal system that we will encounter as we review fluoroscopy of the esophagus in the next two episodes, and thereafter fluoroscopy of the bowel. I will post a free downloadable study guide on my website, theradiologyreview.com, after each of these episodes is posted. And without further ado, let's get into the questions and answers for this episode. First question: what are advantages of fluoroscopy compared to other medical imaging techniques? This is the only general question I have in this episode, but I wanted to cover this now because I just simply wanted to point out and get you thinking about the utility of fluoroscopy in medical imaging. Fluoroscopy allows real-time imaging via X-rays of internal structures, often used to evaluate fluid moving through various organs like the esophagus, stomach, bowel, and bladder, as well as blood vessels. Fluoroscopy is also helpful for procedures to allow real-time guidance of catheters and needles, such as with many interventional radiology techniques. When speaking of fluoroscopy of the gastrointestinal system and mentioning that we evaluate fluid, what I more specifically mean is that we evaluate the movement of barium as well as the coating of barium throughout the specific organs of interest, be it the esophagus, stomach, small bowel, or large bowel. And by observing the movement and coating of barium on fluoroscopy, certain disease states as well as motility and patency of the gastrointestinal system can be assessed. Let's now get specifically into esophageal fluoroscopy. First question: how can gastroesophageal reflux disease and Barrett's esophagus look on a barium swallow study? With most pathologic entities that cause inflammation of the GI tract, thickened folds can be seen on barium fluoroscopy studies due to edema within the normal folds of the GI tract. And this is true for reflux esophagitis, wherein you would see thickened folds of the esophagus as a manifestation of edema and inflammation that may occur due to the irritant effect of the acid and subsequent esophagitis. If there is coexistent Barrett's esophagus, this could appear as a reticular mucosal pattern on a dual contrast esophagram, which may have associated stricturing. Risk factors for Barrett's esophagus include a hiatal hernia with associated gastroesophageal reflux disease. Both gastroesophageal reflux disease and Barrett's esophagus can look normal on a fluoroscopy study, but for radiology board exams, we will simply be focusing on this and other topics on how these could appear when they are asking you questions about these disease states. And if they're asking you about GERD or Barrett's esophagus, it is more likely that they will simply show you the abnormal disease states that you can see on a fluoroscopy study. Next, Is gastroesophageal reflux disease with Barrett's esophagus most classically associated with development of esophageal adenocarcinoma or esophageal squamous cell carcinoma? The answer I am looking for here is that Barrett's esophagus is most classically associated with development of esophageal adenocarcinoma. Next, what are classic risk factors for esophageal squamous cell carcinoma? For radiology board exams, I would remember that heavy alcohol use and chronic smoking are both classic risk factors for esophageal squamous cell carcinoma. Next question. What are classic esophageal locations, meaning proximal, mid, or distal esophagus, for esophageal squamous cell carcinoma and esophageal adenocarcinoma? I would definitely remember that esophageal squamous cell carcinoma classically develops in the mid-esophagus, or you could simply remember the upper to mid-esophagus. With esophageal adenocarcinoma, I would certainly remember that this classically develops in the distal esophagus, often near the gastroesophageal junction. Next question. What is the so-called Schatzki ring? And that is spelled S-C-H-A-T-Z-K-I. What is the so-called Schatzki ring? Notable narrowing of the normal B ring, B like boy, B ring, which demarks the gastroesophageal junction, is termed a Schatzki ring. Note that the B ring normally demonstrates slight constriction, and that is normal, but excessive narrowing beyond physiologic levels would qualify it for a Schatzki ring, with some also saying that symptoms of esophageal dysfunction must also be present to diagnose a Schatzki ring. Schatzki rings are commonly seen in association with things like a hiatal hernia and with gastroesophageal reflux. Next question. True or false? Barium fluoroscopy of the esophagus is more sensitive than endoscopy for detection of a Schatzki ring. The answer here is true. Barium fluoroscopy of the esophagus is indeed more sensitive than endoscopy for detection of a Schatzki ring. Next, true or false? Single contrast fluoroscopy is more sensitive for detection of a Schatzki ring than a dual contrast fluoroscopy technique. The answer here is also true. Single contrast barium opacifies the entire esophageal lumen and allows improved visualization of narrowing associated with a Schatzki ring. And in case you need a reminder, single contrast fluoroscopy typically involves barium alone, whereas dual contrast involves both barium and CO2 or other air contrast, and both are therefore used for evaluation in a dual contrast fluoroscopy evaluation. Next question. How is a Schatzki ring commonly treated? If a Schatzki ring is severe enough to require treatment, it can be treated by pneumatic dilatation or performance of multiple biopsies or other mechanical disruption around the ring to open up the narrowed tissues. Next question, true or false? Chronic reflux esophagitis is a major risk factor for esophageal pseudodiverticulosis. The answer here is true. As the name contains diverticulosis, you would be correct in assuming that esophageal pseudodiverticulosis looks like multiple small outpouchings of the esophagus with multiple small diverticuli. These outpouchings can also demonstrate a floating appearance, as if the pseudodiverticuli are floating next to the esophageal wall, because you may not always have contrast within the entire connection between the outpouchings and the esophagus to see the entire connection. I would encourage you, for this and multiple other entities that I will describe, to look up on an image search what a specific entity I'm discussing looks like. And in this case, I definitely would encourage you, if you do not know what this looks like, look up images of esophageal pseudodiverticulosis. And remember that this is classically associated with chronic reflux esophagitis as a major risk factor. Next question. What is the classic esophageal pathology to suspect on a board exam if you are given a clinical history of a wind instrument performer or a glass blower? Now, this question was perhaps a little bit misleading because the answer I'm looking for is a lateral pharyngeal pouch, which is a protrusion of the lateral pharyngeal wall that can fill with barium. This is admittedly not in the esophagus, but this is pathology that can be seen in the hypopharynx on an upper GI study, including an esophagram. So definitely remember, if you are given a clinical history of a patient who is a wind instrument performer or a glass blower, and they show you what looks like an esophagram, you need to be on the lookout for a lateral pharyngeal pouch, which is the protrusion of the lateral pharyngeal wall, and you would be looking for that protrusion to be filled with barium for diagnosis. Next question. True or false? A Killian-Jamieson diverticulum arises from the hypopharynx. The answer here is false. A Killian-Jamieson diverticulum arises from the anterolateral cervical esophagus. And this kicks off a few questions talking about locations of pathology on an esophagram, and this is actually somewhat high yield in my opinion. And if you need to review this in writing, refer to the free downloadable study guide you can access at theradiologyreview.com. Next, true or false? A Zenker diverticulum arises from the hypopharynx. The answer here is true, and perhaps even more importantly, you need to remember that a Zenker diverticulum arises from the posterior hypopharynx. If you could only remember one of these, I would probably choose the Zenker diverticulum arising from the posterior hypopharynx, although the lateral pharyngeal pouch with a wind instrument player is also important, and bonus points if you can also remember the Killian-Jamieson diverticulum that arises from the anterolateral cervical esophagus. Next, true or false? A Zenker diverticulum is a false diverticulum. The answer is true, that a Zenker diverticulum is a false diverticulum. This means that the diverticulum does not contain all three esophageal layers, but rather the mucosa and submucosa are the layers that herniate through the muscularis layer. And therefore, it is a false diverticulum, as a true diverticulum would be a diverticulum that contains all three layers, including the muscular portion. Next, true or false? A Zenker diverticulum is considered a Pulsion diverticulum. The answer here is true. A Zenker diverticulum is considered a Pulsion diverticulum, and this gets into the minutia that can be asked around these fluoroscopy type questions. For example, you could be shown an image and feel very good about yourself that you know this is a Zenker diverticulum. It is arising posteriorly from the hypopharynx. But then they could hit you with a further question asking whether this is a true or false diverticulum. So in my opinion, fluoroscopy is no joke. These disease entities are very important for radiology board exams and is worth your time reviewing. Next question. What is a pulsion diverticulum, and how does this vary from a traction diverticulum? A pulsion diverticulum results because of herniation of the esophagus through the muscular layer due to increased intraluminal pressure. Because there is no muscularis in the diverticulum, once barium enters, a pulsion diverticulum typically would not readily empty the barium again, unlike a traction diverticulum. A traction diverticulum does contain all three layers of the esophageal wall, and therefore is a true diverticulum, and can empty barium due to constriction of the diverticulum due to presence of muscle in the diverticulum wall. A traction diverticulum often results from external pulling on the outside of the esophagus, and the traction or pulling of the esophagus in a traction diverticulum can result from processes such as tuberculosis of the mediastinum that can tether and pull on the esophageal wall, therefore forming a traction diverticulum, whereas a pulsion diverticulum results from internal pressure, increased internal intraluminal pressure, rather than external traction or pulling with a traction diverticulum. Next, true or false? A traction diverticulum most commonly arises from the hypopharynx. The answer here is false. A traction diverticulum most classically arises from the mid-esophagus, and remembering the example I said of something like tuberculous involvement of lymph nodes or other structures in the mediastinum tethering and pulling on the esophagus can make you see that this is most likely to happen in the mid-esophagus because that is where the majority of mediastinal processes and structures exist, because that portion of the mediastinum surrounds the mid to perhaps slightly distal portion of the esophagus. Next, is an epiphrenic diverticulum typically a traction or a pulsion diverticulum? The answer I'm looking for here is pulsion, and as the name would suggest, an epiphrenic diverticulum arises from the distal esophagus just above the level of the diaphragm, and it is a pulsion diverticulum, meaning that it results from increased intraluminal pressure pushing the diverticulum outward. Next, what is the classic appearance of Candida esophagitis on a barium swallow study? The main presentation I would remember for Candida esophagitis is that of discrete plaque-like lesions, which can be separated by normal mucosa and may also show areas of ulceration, which are typically small. The alternative presentation for Candida esophagitis is a shaggy and irregular mucosal surface, which tends to be a more advanced presentation that occurs when the otherwise discrete plaques coalesce due to the long-standing nature, in this case, of Candida esophagitis. Again, please look up pictures of this if you do not already know what this looks like. Next, what is a classic clinical history for a patient with Candida esophagitis? With Candida esophagitis on a multiple choice exam, you may be prompted to consider this entity after being provided with a clinical history of AIDS or other immunocompromised state in a patient with dysphagia and or oral thrush. However, the presence of oral thrush is not obligatory for a diagnosis of Candida esophagitis, but typically I would be surprised if they ask you about Candida esophagitis without some history of AIDS or immunocompromised state, such as organ transplantation on immunosuppressive therapy. Next question. Whereas AIDS is classic for a person with Candida esophagitis, what are potential manifestations of HIV in the esophagus? HIV of the esophagus can manifest as long and shallow esophageal ulcers without the classic plaque-like thickening and typical small ulcers that are often seen with AIDS and Candida esophagitis. But HIV on its own, even without any severe degree of immunosuppression, can affect the esophagus, and again, that would appear typically as long and shallow esophageal ulcers. Next, true or false? CMV, meaning cytomegalovirus esophagitis, can appear very similar to HIV esophagitis. The answer here is true, although ulcers can also be small, whereas with HIV, the classic is long and shallow ulcers. The longer yet shallow ulceration typical of HIV esophagitis can also be classic for CMV esophagitis. CMV gastritis is also possible and classically shows luminal narrowing and nodular mucosal thickening on a barium study involving the gastric antrum. Expect with CMV a history of an immunocompromised state, whether referring to CMV esophagitis, gastritis, or enterocolitis. Next question, true or false? Herpes esophagitis is also an opportunistic infection in patients who are immunocompromised. The answer here is again true. Herpes esophagitis is also classically seen in patients who are immunocompromised, similar to CMV esophagitis and Candida esophagitis. Last and final question for this episode. What is the classic appearance of herpes esophagitis on a barium esophagram? With herpes esophagitis on a barium esophagram, think multiple small ulcers with a classic lucent halo surrounding the ulcers, most classically in the mid-esophagus. And the key with herpes esophagitis is not only that ulcers are classically small, but perhaps more importantly, the classic lucent halo that surrounds those ulcers is more classic for herpes esophagitis. Once again, if you do not know what that looks like, please look up images and make sure that is very clear for you. And if you want to review all of this in writing, please download the free study guide on my website, theradiologyreview.com, under the study guide section. I hope this episode was helpful for many of you. Definitely tune into the next episode on esophageal pathology because there are many, many more important and high-yield disease states of the esophagus that you need to be familiar with for radiology board exams. If you have other episode suggestions that you would like to make, you can email me at theradiologyreview@gmail.com. And I really appreciate your support and your listening to this podcast. So keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version. Hey listeners, have you checked out our Instagram page? It's a great resource for daily facts. Follow us at RadRev Podcast.